Welcome to part 2 of the Improving the Early Identification and Treatment of Patients with Chronic Kidney Disease webinar recording. This webinar was recorded on the 26th of August 2021.
Hello, I am Paola Fioretto, Professor of Medicine at the University of Padova in Italy. I am an endocrinologist and my clinical and research interest is predominantly on diabetic kidney disease. I'm very pleased to be part of this program today to discuss on the new treatment option that we can offer to our patients with diabetic kidney disease. Indeed, in the last years, we have learned from large randomized clinical trials that SGLT2 have important nephroprotective effects. The initial indication in this regard came from the cardiovascular outcome trials, suggesting that SGLT2 inhibitors have strong nephroprotective effects. There are two completed renal outcome trials, the CREDENCE and the DAPA-CKD, that clearly confirm these important effects in slowing progression of renal disease. The CREDENCE trial enrolled patients with type 2 diabetes and advanced kidney disease, and the DAPA-CKD enrolled patients with chronic kidney disease, both with and without diabetes. This slide shows the renal effects of SGLT2 inhibitor reported in the cardiovascular outcome trials. The first one to be completed was the EMPA-REG cardiovascular outcome trial, which clearly demonstrated a reduction in the composite renal endpoint. Very similar effects on the composite renal endpoints were reported in the CANVAS trial and in the DECLARE-TIMI. Despite the fact that the renal composite endpoints were slightly different, being doubling of serum creatinine in end-stage renal disease and renal death in EMPA-REG, and 40% reduction in GFR, end-stage renal disease and renal death in the CANVAS and in DECLARE program, you can appreciate that the reduction in the renal risk was very similar in the three trials, with the relative risk reduction ranging from 40 to 47%. So very strong nephroprotective effect. In addition to this effect in slowing progression towards renal failure, all these agents, empagliflozin, canagliflozin, and dapagliflozin, demonstrated a positive influence on albuminuria, in that patients receiving these agents were less likely to develop macroalbuminuria and also to develop microalbuminuria. Also, in patients with macroalbuminuria, in all trials, there was a significant reduction in albumin-creatinine ratio. The confirmation that SGLT2 inhibitors have nephroprotective effect came from the renal outcome trials. The first one was the CREDENCE trial performed in patients with type 2 diabetes with GFR between 30 and 90 and with an albumin-creatinine ratio exceeding 300 milligrams per gram. Patients had to be on a maximum tolerated dose of ACE inhibitors or ARBs, and then they were randomized to either canagliflozin 100 milligram or placebo. The trial was stopped earlier for proven benefit after 2.6 years. The primary endpoint was a composite of end-stage renal disease, doubling of serum creatinine, renal or cardiovascular death, and then there was a specific renal composite renal outcome without cardiovascular death and a cardiovascular outcome with cardiovascular death and hospitalization for heart failure. These are the results of the CREDENCE trial, a significant reduction in the relative risk by 30% to reach the primary endpoint, which was a composite of end-stage renal disease, doubling of serum creatinine, renal or cardiovascular death. Looking at the individual components of the endpoint, you can clearly see that there was a reduction in the risk of doubling serum creatinine in end-stage renal disease. Importantly, there was also a reduction in the risk of cardiovascular death that almost reached statistical significance with a p-value of 0.05. And I think that this is a very, very important result of this trial. We know that patients with chronic kidney disease have very high cardiovascular risk. The DAPA-CKD was the second renal outcome trial to be completed. There is still one ongoing, is the EMPA-Kidney. And the interesting part of this trial was that the patients with chronic kidney disease were enrolled, but not only patients with type 2 diabetes, also patients without diabetes, meaning patients with chronic kidney disease who had hypertensive nephropathy or glomerulonephritis. And in fact, 32% of the patients in DAPA-CKD did not have type 2 diabetes. Inclusion criteria were albuminuria above 200 and a slightly lower GFR between 25 and 75. Patients were randomized to dapagliflozin 10 milligrams or placebo, and also this study was stopped earlier for evident benefit. You can see that the composite renal endpoint was a 50% decline in GFR, end-stage renal disease, renal or cardiovascular death, and the results were very similar to those observed in the previous trial, with a relative risk reduction of 36% in the diabetic population and even more in the non-diabetic population, 50% reduction in relative risk. Thus, in DAPA-CKD, there was a 44% reduction overall in the general population, diabetics and non-diabetics, to develop the composite renal endpoint, a 29% to have a decrease in the risk to have cardiovascular death, also hospitalization for heart failure, and very importantly, a 31% relative risk reduction of all-cause mortality. So clearly, this treatment affected all-cause mortality. From the safety point of view, the drug was very well tolerated without any signal for an increased risk of ketoacidosis, hypoglycemia, fractures, amputations, etc. Patients with chronic kidney disease very frequently have cardiovascular disease and also heart failure. And a very interesting study was performed with dapagliflozin in patients with heart failure and reduced ejection fraction. With a similar study design of the DAPA-CKD, also DAPA heart failure enrolled not only patients with type 2 diabetes, but also patients without diabetes. And you see that 55% of the patients in DAPA-HF did not have diabetes. Patients were enrolled to dapagliflozin 10 milligrams or placebo, and the treatment with dapagliflozin was able to significantly decrease the risk of the primary endpoint, which was a composite of cardiovascular death and worsening of heart failure. And you see that when these two components were considered separately, there was a significant reduction in the risk of cardiovascular death as well as hospitalization for heart failure. Thus, also in DAPA-HF, the safety profile was extremely good, without any signal for an increased risk to develop any kind of complication, with the exception, of course, of genital infection, which is always a risk that needs to be considered when we treat patients with SGLT2 inhibitors. Thus, when it comes to dapagliflozin, we have evidence from the DAPA-CKD trial that in patients with advanced diabetic kidney disease, there is a decreased risk to progress to end-stage renal disease. There is a decreased risk of cardiovascular death and hospitalization for heart failure, and decreased risk of all-cause mortality. In DAPA-HF, in patients with heart failure, and reduced ejection fraction, there is a decreased risk of cardiovascular death and worsening of heart failure. In addition, also in this trial, it was documented a reduction in the renal endpoints. And finally, in the DECLARE TIMI trial, the cardiovascular outcome trial, it was demonstrated not only a cardiovascular benefit, but also a very important nephroprotective effects, not only in terms of progression towards end-stage renal disease, but also in terms of development of early nephropathy. In fact, patients receiving SGLT2 inhibitors had a decreased risk to develop micro or macroalbuminuria and had an increased likelihood of improving albuminuria category, meaning regressing from macroalbuminuria to micro or from macro to normal. Current guidelines, of course, take in consideration the results of these important studies, and in the management of patients with diabetic kidney disease, they recommend, in addition with ACE inhibitors and ARBs, the use of SGLT2 inhibitors. The guidelines are slightly different in that in the ADA guidelines, it is suggested to start SGLT2 inhibitors when GFR is of at least 30 or above, and when patients have micro or macroalbuminuria, while in the cardiology and KDIGO guidelines, it is recommended to use these agents when GFR is of 30 or above, regardless of albuminuria. As far as a GLP-1 receptor agonist, it is well known that these agents have a positive influence on the progression of albuminuria and also that they decrease cardiovascular events, and they are recommended as an addition to SGLT2 inhibitors when glycemic control is not achieved with the agents that are used in that individual patient. More in detail, the KDIGO guidelines recommend in patients who are drug naive and receive and have diabetic kidney disease to start with metformin and SGLT2 inhibitors, and to add GLP-1 receptor agonist when glycemic control is not reached. The European Society of Cardiology and European Association for the Study of Diabetes in the management of patients with type 2 diabetes recommend to phenotype the patient, and in the drug-naive patient, if the patient has established cardiovascular disease or chronic kidney disease, to start with SGLT2 inhibitor or GLP-1 receptor agonist, even if the patient is not receiving metformin. If patient is on metformin, they recommend to use these agents when established cardiovascular disease is present. The ADA guidelines recommend that patients with type 2 diabetes with chronic kidney disease should be treated with an SGLT2 inhibitor, and if glycemic control is not achieved, a GLP-1 receptor agonist should be added. Finally, the Primary Care Diabetes Europe position statement along the same lines recommend for patients with chronic kidney disease and diabetes, metformin and SGLT2 inhibitors start away. Thus, in conclusion, type 2 diabetes is associated with an increased risk for the development of chronic kidney disease, heart failure and cardiovascular disease, and fortunately, in the last years, we have nephroprotective agents that are available to our patients with type 2 diabetes. And current guidelines recommend to consider initial combination therapy with metformin plus an SGLT2 inhibitor for patients with type 2 diabetes and chronic kidney disease in order to decrease renal and cardiovascular outcomes. I thank you very much for your attention, and I will be happy to address any questions that you may have.